Hi everyone, welcome back. Today we are diving into one of the most important yet often intimidating investigations in critical care, arterial blood gases or ABGs. By the end of this video, you will be able to identify normal and abnormal ABG values and their clinical significance. Apply a systematic 5-step approach to ABG interpretation. Recognize the 4 primary acid-base disorders and their compensation patterns. Make evidence-based physiotherapy decisions based on ABG findings. Integrate ABG interpretation into comprehensive patient assessment. Identify when ABG results require immediate clinical action. Think of ABGs as a three-way conversation between your lungs, kidneys, and cellular metabolism. When one system fails, the others attempt compensation. As physiotherapists, we are primarily influencing the respiratory component, but we must understand the entire conversation. Let's break down each component systematically. First, pH, the master regulator. pH measures hydrogen ion concentration with normal values between 7.35 and 7.45. Why does this matter for physiotherapy? A patient with acidemia, pH below 7.35, may have impaired respiratory muscle function, affecting their ability to participate in treatment. Alkalemia, pH above 7.45, can cause hyperexcitability and muscle cramps, influencing exercise tolerance. PaCO2, the respiratory indicator. PaCO2 or partial pressure of carbon dioxide reflects ventilation effectiveness. Normal range 35 to 45 mmHg. This is your domain as a physiotherapist. High PaCO2 above 45 mmHg indicate hypoventilation or ventilatory failure. This screams for respiratory intervention. Low PaCO2 below 35 mmHg suggests hyperventilation, possibly compensatory for metabolic acidosis or anxiety related overbreathing. HCO3, the metabolic component. Bicarbonate, normal range 22 to 26 milliequivalent per liter, represents the metabolic component. The kidneys regulate this, but it directly impacts our respiratory interventions. Low bicarbonate suggests metabolic acidosis. Think diabetic ketoacidosis or renal failure. High bicarbonate indicates metabolic alkalosis, often from vomiting or diuretic use. Understanding these helps you to anticipate respiratory compensation patterns. PaO2 and SaO2 assess oxygenation. PaO2 normal ranges 80 to 100 mm of mercury. SaO2 should be 95 to 100%. But here is the critical threshold. PaO2 below 60 mmHg indicates severe hypoxemia requiring immediate action. Now for the systematic approach that will prevent errors and ensure a comprehensive assessment, I will call this the acidosis method, a 5-step mnemonic that covers everything. Assess oxygenation first. Hypoxia kills faster than the acid-base disturbances. Look at PaO2 in context of inspired oxygen concentration. If PaO2 is less than 60 mm of mercury, this becomes your immediate priority. Everything else waits. Optimize positioning, consider airway clearance, evaluate ventilation perfusion matching. Check pH status. Is your patient acidemic, alkalemic, or normal? Use 7.40 as your reference point. Identify the primary disorder. Is this respiratory or metabolic in origin? Here is the key principle. pH and the primary component move in the same direction. Determine compensation. The body never overcorrects. If pH normalizes, suspect mixed disorders. Respiratory compensation for metabolic disorders happens quickly, minutes to hours. Renal compensation for respiratory disorders takes days. This timing helps you to understand chronicity. Observe and correlate clinically. Never treat numbers in isolation. How does the patient look? What's their work of breathing? How are they responding to treatment? Red flags requiring immediate action: pH below 7.25 or above 7.55, PaO2 below 60 mm of mercury, rapidly rising PaCO2 or clinical deterioration despite improving numbers. Let's dive deep into each acid-based disorder, starting with respiratory acidosis. Respiratory acidosis occurs when PaCO2 rises above 45 mm of mercury with a corresponding drop in pH below 7.35. Think of it as ventilatory failure. The lungs can't eliminate CO2 effectively. Your intervention targets CO2 elimination, positioning for optimal respiratory mechanics, airway clearance techniques, breathing exercises to improve ventilation distribution, and in mechanically ventilated patients, manual hyperinflation and vibration. Respiratory alkalosis, pH above 7.45 with PaCO2 below 35 mm of mercury, usually caused by hyperventilation, but remember, it might be appropriate compensation for metabolic acidosis. Primary respiratory alkalosis from anxiety or pain responds to breathing retraining and relaxation techniques. Compensatory respiratory alkalosis for metabolic acidosis should not be suppressed. Support it instead. Metabolic acidosis, pH below 7.35 with bicarbonate below 22 milliequivalent per liter. The respiratory system attempts compensation through hyperventilation. You will see this as Cosmol breathing. Support respiratory compensation while monitoring for respiratory muscle fatigue. These patients often have deep rapid breathing. Don't interfere with this compensatory mechanism, but be prepared to modify intervention if fatigue develops. Metabolic alkalosis, pH above 7.45 with bicarbonate above 26 milliequivalent per liter, often caused by vomiting, diuretic use, or hyperaldosteronism. These patients may have suppressed respiratory drive as compensation. Be extremely cautious with respiratory intervention that might further suppress ventilation. Real patients don't read textbooks. Mixed disorders occurs when multiple processes happen simultaneously, creating complex ABG patterns that challenge even experienced clinicians. Mixed disorders require comprehensive assessment and often multidisciplinary management. Support the respiratory component while avoiding interference with other compensatory mechanisms. When in doubt, consult with the medical team before proceeding with aggressive interventions. Mechanically ventilated patients often present unique ABG interpretation challenges. The ventilator controls PaCO2, but your interventions still significantly impact oxygenation and overall gas exchange. Poor ventilator synchrony can create misleading ABG results. A patient fighting the ventilator may have normal ABGs despite significant work of breathing. Your chest physiotherapy can improve synchrony and reduce work of breathing. ABG trends during weaning trials provide crucial information. Rising PaCO2 with falling pH suggests respiratory muscle fatigue. Weaning should be discontinued. Stable or improving ABGs support weaning progression. Let's apply our systematic approach to real cases. Treatment priorities: address hypoxemia first with positioning and oxygen therapy, then focus on CO2 elimination through airway clearance and breathing exercise. Monitor closely for fatigue. Let's discuss another patient. Primary respiratory alkalosis with hyperventilation, likely anxiety related. Oxygenation is adequate, treatment focus, breathing retraining, relaxation techniques, pain management optimization. Let's see another case. This is mixed metabolic acidosis with incomplete respiratory compensation. Support respiratory compensation while addressing oxygenation. Chest physiotherapy may help, but monitor for signs for fatigue. Certain ABG findings require immediate action, regardless of your treatment plan. pH below 7.25 or above 7.55. Immediate medical consultation required. PaO2 below 60 mm of mercury, severe hypoxemia, optimize oxygenation immediately. Rapidly changing values, trending worse despite treatment, reassess immediately. Clinical deterioration with normal ABGs, something else is wrong, comprehensive reassessment needed. Let's review our systematic approach. Assess oxygenation first, check pH status, identify primary disorder, determine compensation, and always correlate clinically. This method prevents errors and ensures comprehensive assessment. Thank you for joining me for Decoding ABGs, a physiotherapist clinical insight. If you like this video, give a thumbs up and comment down below your ABG scenarios and treatment plans. Share this video, and if you are new here, press that subscribe button and hit the bell icon so that you never miss our videos.